Hello, this is Dr. Shen again from Columbia University, New York Presbyterian Hospital. And hopefully so far you enjoyed our conference and the topics. And my next topic is a post-operative care of Crohn's disease. So as we know, if your Crohn's disease has a natural history, the majority of the patient will develop symptomatic or asymptomatic disease recurrence or endoscopic recurrence. So this is a nice trial called a POSTER trial. Some of the our South American colleague with the part of the co-author. That basically it's determined if the post-operative colonoscopy can change a disease management or not. So this study designed 6 months after ileocolonic resection with the ileocolonic anastomosis, 6 months do the colonoscopy, and based on the colonoscopy finding, you decide to escalate the medical therapy or not, versus no post-operative colonoscopy. You compare the two groups, actually disease outcome is different. Patient with 6 months post-operative colonoscopy yield better the medical outcome in terms of the disease recurrence and disease management. So this is a landmark study called a POSTER trial that determined the Variety Society post-operative endoscopy colonoscopy is a critical role in the management of the post-operative disease recurrence. So endoscopy recurrence after 18 months, you can see the different group, controlled arm and active arm with the endoscopy 6 months. So the ASGE guideline, consensus guideline consists of the expert in the United States in the IBD, and we recommend ileocolonoscopy to monitor disease activity should be performed 6 to 12 months after ileocolonic resection and ileocolonic anastomosis. So this is the common surgery we performed for Crohn's disease. Ileocolonic resection resect the fistula, inflammatory bowel disease or structure in the junction between the ileum and the colon, along with the ileocecal valve. Common anastomosis, this one is called side-to-end anastomosis. Sometimes we perform the side-to-side anastomosis. Patient may carry the temporal ileostomy, may not, depend on the disease stages and then the experience of the surgeons. So I want to show you some of the slides and the anastomosis. Sometimes you hard to identify the opening, like this here. Side-to-side anastomosis. Sometimes you can intubate the side-to-side anastomosis with the retroflex. You can see the inflammation in the neoterminal ileum. Some erosions, already see the disease recurrence, multiple erosions. This we call Rokas 2 classification. And next one. So Lucas, Professor Lucas, a giant in the IBD care, and 30 years ago he published this Lucas score, defined the disease recurrence in the they call it I means ileum, 0 means no inflammation, 1 is like the small erosions, and 2A, 2B. 2A, that means more than 5 erosions in the is a 2B when the 5 erosions in the neoterminal ileum. 2A, that means erosion or ulcer in the anastomosis. If you have the large ulcers, if you have the stricture, or if you have the blockage, you are classified as a Lucas 3. Okay. Next one, it is the reminder score. There's a group of the investigator proposed there's an anastomosis area, no inflammation, or there's a small inflammation, or the inflammation more than 50% of the circumference, or the whole circumferential is inflamed. These are A1 means anastomosis A0, A1, A2, A3. The investigator believer is the A2, A3 or higher grade of the anastomotic erosions is associated with a high risk for disease recurrence. Now, there's a new surgery is performed called CROHN anastomosis. The investigator believe they perform this wide patent anastomosis may decrease risk for the post-operative disease recurrence. So I showed some picture, the scope. You can see this is the wide opening of the anastomosis. You can still see there's some staple there. And then the lumen of the neo-terminal ileum is wide. So far, my feeling it is anastomotic structure become less, but however, anastomotic ulcer erosion appear to be still exist. So this is the CROHN anastomosis. So that when you do the colonoscopy, to make sure they have a correct documentation of the what kind of anastomosis were surgeon created. Yeah. Now, there are different kind of ostomy, and ileostomy, loop ileostomy, and then even the people with the ileal pouch surgery and the loop and ileostomy. Very careful when you intubate the both end. Make sure the patient, if you have the loop and ileostomy, sometimes if you try to bluntly push the scope here to the efferent limb, that can cause perforation. Okay. So ileoscopy, how do we do that? Sometimes, it's a very straightforward. You for the efferent limb, which is with the exposure to the stool string, then you come back, and then underneath it, typically it's buried this with the efferent limb. You can see the area which is diverted, mainly has a mucus and sometimes it has a mucobasal. So when you do the scope, make sure it's end ileostomy or loop end ileostomy or loop ileostomy. Here is sometimes the stoma can be associated with a peristoma hernia, make the intubation difficult. You may have a looping in the herniated area. What do? You ask your assistant to hold of the area around the stoma. You can introduce the scope there. So how do we define the structure in people with ileostomy, right? So there's commonly there's area we call the fissure area, had the physiological or the structural narrowing due to the pinch of the fissure. If we have a narrowing the area, it's not necessary is a Crohn disease associated. It's likely it's a pinch of the mesenteric artery and it caused the structure. It's nothing to do with the Crohn disease. If you have a structure down below that more than 10 or 15 centimeters from the stoma, and then it is the structure likely from the Crohn disease. So when you have the structure of the stoma, you make sure you document where the structure located. 5 centimeters from the stoma, 10 centimeters from the stoma, or the further. So keep in mind the fissure side structure can happen. Now, how about the score in the ileoscopy? So we use a Rocket score to the people with the neo-terminal ileum with the people with the stoma. Same thing, IO0, I1, IO2, IO3, IO4. And actually the outcome is reflect actual Rocket score is also applied for the people with the ileostomy. So then this is the patient with a high Rocket score associated more risk for readmission, endoscopic structure dilatation, or surgery. Now here is a structuroplasty side. Sometimes intubated structuroplasty side may be challenging. And this is the duodenal structuroplasty. Structuroplasty side normally consists of the lumen and inlet and outlet. So here is the inlet and outlet structure. Then the lumen of the structuroplasty side typically look normal, but the outlet and the inlet area can often get narrowed. So look at for the structuroplasty side. So you introduce into the small bowel, and you can see the further. This is that we perform an ileocolonoscopy through the ileocecal valve and then reach the about 20 centimeters from the terminal ileum or ileocecal valve. You can see the one of the narrowed area here. So this is a structuroplasty side outlet. Yeah, go into outlet, ulcerated, and narrowed too. This is the outlet, and the other one, sorry, is the inlet. Outlet, the other one is inlet. Yeah, the inlet. This is the lumen of the structuroplasty side. Quite often, the inlet is at the side. Then those patients have quite often suffered from the small bowel bacterial overgrowth, this retroflex, and you need to find the inlet. Inlet, yes, inlet is here. Inlet is open. Okay, it's very good. And the patient still have the diffuse mucosal inflammation with the mucus, some inflammation there. Okay, so when you intubate the structuroplasty side, make sure you document the inlet and outlet and the lumen. How about the diverted bowel? So variety of reason people have a diverted bowel, then with the ileostomy or colostomy, loop colostomy or loop ileostomy. Then your part of the bowel is diverted. That patient had a diverted bowel and a suture into the abdominal wall, and that sometimes it can cause a fistula. We call it mucus fistula. The mucus fistula is intentionally created. When you sealed here, the surgeon tried to prevent the free perforation from the stump, so they suture the stump into abdominal wall, just in case there's a perforation to make the cutaneous fistula, and then save the people from the development of the free peritonitis. Okay. Now, sometimes people with a long-term diversion can have the totally sealed outlet like this one. Then quite often we use a jag wire to find the lumen, and over the jag wire we use the knife, either IT knife or needle knife, to open the structure. Then challenging one would be diversion associated structure can be long, and people can have diversion proctitis, diversion pouchitis. Mucosa will be very friable. If you do the endoscopy therapy, the bacterial translocation can happen with the bacteremia. So in our routine practice, now we do the antibiotic prophylaxis for the diagnostic and therapeutic endoscopy in the people with the long-term diverted pouch or diverted rectum. Diverted rectum, sometimes we call the Hartmann pouch. So I show the video here. This is the diversion associated structure, almost totally sealed. So this one, we see the lumen. We already use the guide wire, see the orientation of the lumen, so we pull the guide wire out, and we use the needle knife to treat. So with a gentle insufflation, and then cut the structure. Then after cut the structure, you know, IBD patient required the yearly the surveillance. With this, you get access to the diverted bowel. You can do the surveillance biopsy. So here is a bypass surgery. Occasionally, you can see the bypass surgery. This the patient have the severe duodenum, CROHN disease. The patient had gastrojejunostomy, and then you will know this is an area diverted bowel. sometimes they develop a pre-cancer or cancer condition. So you can, during each time you do the endoscopy, try to reach the duodenum, seal the duodenum area, take some biopsies, and also you can intubate through the anastomosis gastric jejunostomy into the jejunum to monitor the disease activity. So here is a gastric jejunostomy. Here's the stomach. Here the stomach, you can see it, and then you could now you reach the jejunum. You reach the jejunum, and the jejunum is clean, no active disease. That means a Crohn disease in remission of the upper GI tract. And then, if there any chance you're looking for the any sign, any part of the duodenum, so so mainly for surveillance purpose. And then this is this loop jejunostomy, right? And then you go to the other end, which is a part of the jejunum, of the part of the duodenum. You can see you try the dilatation of the duodenum structure, and then later on see if we can put the biopsy forceps for the surveillance purpose. So we hardly now performed the bypass surgery, and in some of the patients for a variety of reasons, and try to avoid resection, and then people do the jejunostomy. Okay, this is a retroflex view. Okay. So how about a post-operative prophylaxis? As we know, then here, this is called network analysis. Basically, showed the up left corner showed the most effective medicine in terms of the efficacy and the side effect to prevent the post-operative prophylaxis. The strongest medicine is again, this is the compared to apple and oranges. This would be the infliximab. Actually, the most data published in the post-operative prophylaxis with a biological agent is infliximab. In my practice, I probably the adalimumab or the vedolizumab and ustekinumab probably equally effective in my mind. So then this study showed use the surface on the cumulative rank, and it suggests actually the adalimumab may be comparable to the vedolizumab and infliximab, depends on what kind of what type of the analysis you performed. So these are my last slides, or also last slides for today. Thank you again for having me. The first ileocolonoscopy, the 6 months to 12 months after surgery. Be familiar with the altered bowel anatomy. Start the biologic agent 2 to 4 weeks after the non-eventful surgery in patients at risk, and with a close monitoring. Then we'll monitor extensive these risk factor for the people with the recurrent Crohn disease, including extensive disease, penetrating disease, history of the multiple surgery, smoker, and the concurrent perianal